We go on to our next speaker, Dr. HEMALATHA GUDISEVA, who's the Director of Cornea and Refractive Services from Shankar Netralaya Chikitsalaya, Vijayawada. And she's going to show us her case. On to you.
So, good evening, everyone. Is my video visible?
Yeah.
Yeah. So, this is a case of phacoemulsification in a patient with post-keratoplasty. So, this patient is actually one-eyed patient. By starting surgery, the infection of the gland.
Doctor, please pause the music. Can you just stop the sound of music coming? Music is coming, just overshadowing the. Can you just mute the video?
You mute the video and talk, HEMALATHA. There's only noise.
On the bottom, the speaker this thing, just mute that. Bottom, niche just speaker ka left, right, iske saath, just mute that.
Or at least decrease the volume. We can't hear what you're trying to say.
Yeah. Okay.
Yeah.
So this patient had usually the challenges we face with these kind of patients is tough observation, well, because of the graft host junction scarring, and there are also many synechiae, posterior synechiae or peripheral synechiae, and sometimes there can be unstable chamber. But though this patient had a lot of synechiae, both posterior and synechiae at the graft host junction, but he had a very good dilated pupil. And the grade of the cataract is slightly between NS1 to 2. But because he is one-eyed, so I had to do cataract surgery for this patient. And because this lens is softer, so I plan to do a slightly bigger excess. Hydrodissection is done routinely. I prefer to do a stop and chop, especially in these patients which has a slightly softer cataract. And other challenges in these patients is IVL power calculation. So we did with the help of IVL Master 700, and we took Barrett's universal formula, and we compared with SRKT formula. Both almost came similar. So after dividing the nucleus, these nuclear pieces were emulsified under the plane of the iris, and care was taken that the chamber is stable throughout the entire procedure, and the nuclear pieces care was taken so that the nuclear pieces don't touch the corneal endothelium. So cortex wash is done. So I prefer to do a non-toric foldable lens in these patients because this is a full thickness keratoplasty, and keeping in view future graft rejection and failure. Though this patient had around minus 6.5 cylindrical power, so I did not place a toric lens. So the lens is dialed into the back. Again, under the visco, I tried to remove some of the synechiae at the graft host junction, but I was successful only to remove 80% of those synechiae. So the rest of the synechiae, I kept them because there can be chances of iridodialysis, and this can make the problem more. So after that thorough visco wash was done, so instead of doing the hydration, I put a tunnel suture so that there is no hydration at the graft host junction, overhydration. So this is a pre-op and post-op pictures. So on day 1, and this is the pre-op topo picture. You can see there is -6 cylinder at 40 degrees, and patient in the post-operative period improved to 6.9 with -2 cylinder at 40 degrees. So that was my case. Thank you very much, madam, for giving me this opportunity.
That was a nice case. Although in a soft cataract, you need not, unless you're going to do a carousel technique or a flip, you need not have made a larger excess. But the other important thing I wanted to ask you was, you could have done the synechiolisis after the cataract surgery, because you had to do it all around. Unless I would have thought of doing a synechiolisis, the AC is so shallow that I can't even get my phaco probe in because it's so shallow. But otherwise, this was a deep, I saw that when you took your phaco probe in, the AC was quite deep. So what is your, I'm not sure whether there's any other cornea person. Dr. Arundhati. Yes, Dr. Arundhati, are you there? We needed a cornea opinion about this. Would you think she could have considered doing a synechiolisis after doing the cataract surgery? Or would you have also done it prior?
I think I would have done it prior only. I think it's a beautifully done case. I should congratulate her, like, and again, as every speaker has said previously, I think it depends on your comfort level. Though the AC was deep, then midway, you don't want any crisis. So whatever is doable actually beforehand, it's better she did it. And I think I would have done the same.
She said another very wonderful thing, that a toric IOL, these corneas can go in for rejection. So
Yes.
it makes no sense to put a toric IOL.
No,
in
it
those
doesn't.
eyes.
We usually don't in these kind of
So then what justifies that 6 diopter of astigmatism dropping down to 2 diopter of astigmatism is an interesting thought.
Yes.
Anybody can think, and what could you have thought of it? It just came up to my mind. I hadn't noticed, unless Hemlata has something to add herself about this. I mean, you have not put a toric IOL in this eye. So the removing of the lens, there was more of a lenticular astigmatism in this eye, or what? Which
No,
could,
topo showed, topo itself showed 5 or 6. No, sometimes patients don't accept so much. And
6.5 cylinder.
yeah.
Sometimes it's just that the patient don't accept. Can I add 2-3 points on?
Yes,
Can
yes.
I add 2-3
Yes, yes.
So
yes.
I would generally go cut the conjunctiva, go a little limbal or a slightly scleral incision for such kind of cases, because invariably I'll end up making the entry at the optic at the graft host junction, and that will be. So I usually do that and put a suture to that also without hydrating too much. And many times when you put a paracentesis, comfort is another point. We have to put it somewhere where comfortable. At that point, there may be total synechy. You may have to pierce through the iris and go in. So that also doesn't actually matter, making a 1 millimeter paracentesis. A larger excision, this one I would not have done because it is not needed, because a smaller one would have covered the optic very well and prevented PCO and all those later. And this one was quite old, is it not? The graft was done quite many years back.
Many years
So
back.
thinking of a rare possibility of this getting decompensated and then the toric IOL going bad, I would definitely have gone for a toric IOL and corrected what was there now. And later on, if the cornea goes bad, then everything goes bad. Then it becomes a more, again, a regraft and a new cylinder coming up and all those. Anyway, we'll have to correct it. So that is my choice. And the BSS, I would have definitely used BSS Plus for this, and a lot of viscoat initially from the beginning itself, because the irrigation itself, in turbulent irrigation itself, can be damaging to endothelium. And so the endothelium should be coated with the viscoat from the beginning till the end of the surgery. And we need to take precautions to take out all the this one also. And if you don't want to put a toric option, another option is to do a pinhole pupilloplasty. But then for that, you need to release all the synechy well, and then the iris should be free and all those. That is for there. A pinhole pupilloplasty is also a possibility. Otherwise, very well done. Corneal endothelial protection is is the cardinal point where she was doing it quite well inside the bag and not bringing it out, and slow and steady, but not too slow to irrigate too much and waste a lot of time in the anterior chamber. Irrigate least and the reduce turbulence to the maximum, reduce the turbulence.
Yeah, wonderful points. And actually, Hemalata, your case was good. This talking about toric and bringing up these things, is not finding fault. It's just that I want to energize the expert panel to come with 1, 2, 3, 4 points like was happened now. So
Yes, ma'am.
very nicely done surgery. It was so clear that your phaco parameters were very optimal and the surgery was below the iris plane.